Hey everyone, let's talk about pneumonia today. So just to start things off, I put up a couple of gram stains. So on your left, you have Streptococcus pneumo. So this is going to be gram positive, which is why it's purple, diplococci, so you can see little pairs of cocci. On your right, we have Pseudomonas. So this is going to be a bacillus, so rod shaped, that's gram negative, that's why it's pink. So this is more common with hospital-acquired pneumonia. So if you have a patient coming to you and they're having a productive cough and fever, you might be suspicious for pneumonia, but before you sort of go full gauntlet with antibiotics, you might want to do a chest x-ray. So the reason why is because it will show a couple of patterns. If you're going to have bilateral infiltrates, so basically kind of a hazy field, you might have some of your atypicals. And a lot of these vignettes will tell you about basically different bugs and how they're related to a certain type of feature. So mycoplasma is typically in teens and young adults, and it may or may not come with a maculopapular rash. Uh, Viruses, common cause. Chlamydia comes with hoarseness. Legionella is really popular because this is pneumonia that is accompanied by diarrhea and hyponatremia on labs. Pneumocystitis, so this is going to be your PCP or PJP. So in immunosuppression under 200 CD4 positive cells, you basically want to be prophylaxing these people with your TMP-SMX. And if they have an infection that's really severe, give them the antibiotic, also give them corticosteroids. So on the flip side, if you have a lobar infiltrate, so you sort of see the solid outline of one of your lung lobes, you might have more of a typical community-acquired pneumonia. So like I said, the most common is strep pneumo. You might have a scenario where a patient had a virus and then they suddenly get much worse because they have a Staph aureus infection. And these can be really nasty because they can create these cavitations inside the lungs, which show up as these little nodules around cavities in the x-ray. Conversely, if a person has really poor dentition, they might get some anaerobes, and their sputum will just be really foul, is kind of how they describe it. Klebsiella is associated with alcoholism and diabetes mellitus. But when you are actually thinking about treatment, you're typically not going to necessarily know what the pathogen is. So a lot of the time, the initial outpatient treatment is going to be based on the severity of symptoms. And so what I mean by that is whether you have atypical or typical pneumonia, and you have somebody that's previously healthy and they haven't had any sort of treatment in greater than 3 months, their symptoms are really mild, you're going to probably consider giving them a Z-Pak, so azithromycin, maybe some clarithromycin or doxycycline. Now, if the patient comes to you and they have comorbidities or they've already had antibiotics for similar symptoms within the last 3 months, but they're still mild enough that you can keep them as an outpatient, think about levofloxacin or moxifloxacin. However, we have this thing called CURB 65, and this is basically the criteria that makes you want to admit a patient. So basically, if a patient comes to you, they have this productive cough, fever, maybe they're having some dyspnea, etc. The things you want to look for are basically the CURB. So just an independent variable, first off, is respiration rates over 30, or if you're getting their gases, a PO2 under 60. But more straightforward with the CURB is confusion, so altered mental status, uremia, if they're in respiratory distress, which I guess can go with the respiration rate above 30, if their systolic blood pressure is less than 90 or they're above 65, so again, CURB 65, admit these people. So when you admit people, this is where you might want to think about tailoring your approach for antibiotics. So you're going to be getting the CBC so you can start trending their white blood cells. But you also want to get a sputum culture and gram stain it so you can think about what the sensitivities are and the type of pathogen. You also might want to consider getting an ABG if they're bad enough to see about any sort of metabolic deformities. So again, you're tailoring now based on the specific pathogen and giving them support. However, if they're in the hospital for longer than 48 hours, you might want to look out for hospital-acquired pneumonia. So basically, this is typically associated with E. coli or Pseudomonas. And Pseudomonas is particularly prevalent in patients who have COPD and adults with cystic fibrosis. So even if the patient's coming to you as an outpatient and they have COPD or cystic fibrosis, they might have Pseudomonas. So these patients, you do not give azithromycin and clarithromycin. You give piptazo or cefepime or some sort of carbapenem like imipenem, but those are starting to get kind of exotic. Now, on the flip side, you could have a patient who's really sick for other reasons and they're on a ventilator. And every day that they're on that ventilator, there's a 5% chance that they will get ventilator-associated pneumonia. So basically, if they start spiking fevers, if they have purulent secretions that start coming up, or if you do a chest x-ray and you see a new infiltrate that wasn't there before, beware. So what we do for this is kind of have to do a deep dive for the sample because basically the ventilator gets the pathogen deep. So you want to be taking samples for the tracheal aspirate, BAL, or brushing deep down in that lung cavity to use for cultures. The treatment, the reflex is basically 2 anti-pseudomonals. So basically starting off with our piptazo, for instance, adding amikacin, and then an anti-MRSA, so vancomycin. But don't use daptomycin because basically that has, it becomes deactivated by surfactant, which is in the lung. Now, the last thing I want to leave us with is basically if we have a lung full of fluid on the chest x-ray and we're thinking, oh, is this going to be empyema? So basically pus in the lungs. So you do the chest x-ray, you have fluid levels, you want to do a thoracentesis, so pulling that fluid out to sample it. Now, there's this thing you should know called the Lights criteria, which basically tells you is the fluid in the lungs basically just fluid in the lungs because of fluid compartment shifts, which is the transitate, or is it more involved, so basically cellular and proteinaceous. So the way you do that is by looking at proteins and lactate dehydrogenase, LDH. So basically if the LDH is greater than 60% the normal serum value, or if it's greater than 50% of the serum's protein value, or if the LDH is greater than 2/3 the upper normal limit for serum, then you want to be thinking about exudate. Now, if all 3 of these things come up negative, that's when you can think about transidate. But, like I said, yes for any one is exudate. In this case, you want to look a little bit deeper for empyema, so you want to see are there a lot of white blood cells, so greater than 1,000 per microliter, or is it very acidic, so the pH is less than 7.2, and this points to empyema, you need to drain it. So, in summary, you have a person who comes in with a productive cough and a fever, you might be suspicious for pneumonia, get a chest x-ray. Strep pneumo is the most common, but again, look at that context. For instance, Legionella, they love to test about that because of diarrhea and hyponatremia. The initial test for outpatients should be based on severity as opposed to the type of pathogen, which you're not typically going to know. So basically, outpatient, you give them azithromycin, maybe clarithromycin, or doxycycline. If they had that comorbidity or were treated in 3 months, give them levo. Or if they match the CURB 65 criteria, you're going to admit them. When you admit them, beware of hospital-acquired pneumonia because this is going to be more of your E. coli anti-pseudomonal types. So anti-pseudomonal, you cover for cefepime or piptazo. Now, flip side, if it's a sick patient that's been ventilated, you really want to get in and deep dive their bronchial secretions for the culture because these patients are going to be the ones with the new fever, purulent secretions, a new finding on x-ray. So you want to give them 2 anti-pseudomonals and 1 anti-MRSA. And again, know and love your Lights criteria for effusions. All right, great job, guys. Study hard.